depending on what night they had. So to introduce day two, I think there's quite a few reflections from day one. We had two really excellent patient speakers at the start and end, and we also had the two speakers on the international view of record sharing as well. So we've had a very big patient and person focus yesterday. And we should always remember that, because that's the key reason why we're here. And the items and the problems that them people raised are why we're here, to stop that happening and prevent it, to make sure they have the best possible care based on the best possible information we can provide. Also, a few other points. We've had Gary McAllister's call to arms. I'm sure Gary's up there. We could to look at where we're going to go on the tech stack. Also, quite a lot of interest on what can NHS England do for us. There's been some interest around what's been happening in farmer outcomes in LLR and West Yorkshire, and is that something we can roll out nationally? Similarly with dentists. Development of GP Connect, where are we? What we're going to do? We've got a big pressure to use that solution. It's very effective, but is it moving at a pace we want? Have we really cracked the information sharing? We're now moving to shared care records using NRL, and that's creating a whole new set of sharing agreements. We all know we love information sharing agreements, and then going around all our practices and organisations and silos and getting them all to re-sign off. There's got to be a better journey, a better way. Social care's take on shared care records is very different to health, and we've got to remember that. And also, just to remind everybody, we are going to, on the closing session, come up with actions and hopefully some owners for them actions from the audience. So please don't think that's the opportunity to run out the room. We'll block the staircase out so you can't escape at that point. Of where do we go? What actions do we need to carry out as a shared care record community? Where can we help our patients, NHS England, ourselves, to deliver that little bit more with the sum of our parts? So that's what I would say is the reflections I've picked up, and I'm sure you all have as well on the sessions and the presentations you've seen. So, for no further ado, I'm going to hand over to Minal Patel to give an update on NHS England on connecting care records. So if you want to come to the stage, Minal.
Okay, good morning everyone. So I'm Minal Patel, Deputy Director for Frontline Digitisation Legislation, but also here to represent Connecting Care today. I'd like to start with a bit of a national update, and then just based on some of the feedback yesterday, maybe I'll dive in a little bit deeper around our interoperability challenge. So first off, the Chancellor announced the 3.4 billion on new investment in NHS digitisation within the spring budget, and this is to be delivered over 25-26. There is the 2% productivity commitment to be delivered, and this level of improvement is only possible with investment in technology and infrastructure, and will be underpinned by our One Digital Estate. There's 2 billion that will be spent on this One Digital Estate, and connecting care records is very much part of this. Discussions are currently underway to determine how the money will be divided between schemes, so look out for more information on that. And we're yet to hear what our spending review settlement is for the next SR period. So I know a few of you have pulled me aside over the last day or so to ask about this. You know, full transparency, it's likely to be very challenging, but we should find out where we land in the next few weeks. So the team and I will definitely pass that information on once we have it to hand. With regards to the operating plan, there is an expectation that the Connecting Care programme will continue to plan for and take steps towards delivering joined-up care and create, those stronger foundations that we need for the future. And whilst it wasn't explicitly mentioned, Connecting Care Records does support the initiatives that were mentioned, specifically, NHS App and NFDP. So to achieve these commitments, the Connecting Care programme has been working across 5 priorities to date, and will continue to do so over the next year or so. And I'll just whiz through those. So we've got the record sharing strategy. We have the interoperability between local shared care records, levelling up of those shared care records, and this pays a particular focus on the capabilities, supplier convergence and how we can get better value for money from our suppliers, and then sustainability. So how do we manage and maintain self-sustaining systems beyond 2025? So, as I mentioned, I'd like to talk a little bit about the national efforts on interoperability and how we're addressing that challenge. So the objective really is, for Connecting Care Records, is expected to complete in 2025, where we hope to see 100% of ICBs involved in interoperability across geographical boundaries. Why is this important? So there's a need to deliver the right data to the right person at the right time for the 20% of acute patient care that is outside ICB-defined boundaries. And I also saw an interesting stat this morning on social media where, according to somebody, there's a billion of us travel across England every year. So there's a definite need there. There's been significant progress on digitising the front line, as I'm sure you know, and although records will be digitised locally through the implementation of EPRs, currently sharing of that information is done by point-to-point interfaces or via our shared care records. So nationally, it's important that we support interoperability standards and tools by encouraging ICSs to focus their investment towards, that deeper collaboration and better interoperability. So last year, the programme built on the MVS1 standard to deliver the level 2 criteria, which focuses on connectivity across care settings beyond that of trusts and general practices, but also includes a richer level of data that's centred around the PRSB Core Information Standard version 2, and also stringent standards around usability and procurement, just to name a few. So as we improve the quality and availability of information within our shared care records, our focus really does need to turn to the exchange of that information. So the slide behind me shows our vision for how health practitioners and patients would operate if information was more readily accessible. Smoother transitions between care settings, quick access to patient information through a central repository, and of course the national scaling to ensure consistent and coordinated care regardless of location. Okay, so just really quickly, we did a recent survey at the tail end of last year on shared care records, and that really did resurface the barriers that systems are faced with. We know that there's limited interoperability across the care setting, and we know that ICS silos are preventing sharing of data for patient flows that require information from other geographies. Now, the DPDI bill that we talked about yesterday provides us with those levers to overcome some of those challenges, but not all. And it will do that by clearly setting open standards that are effectively incentivized and enforced where appropriate. However, interoperability within our systems is too diverse for a one-size-fits-all single approach, and we discussed that yesterday during Gary's session. So where do we go from here? The national programme are designing a twin-track approach to allow for continued development with the existing solutions that are available to us already, namely the National Record Locator, and then a second track to build the target solution, and that may involve IHE or indeed other international standards. And there are 3 principles which we will abide by. This will be an iterative approach. The solution will be built in phases, and this will allow us time to onboard both different vendors and trusts over a period of time. We will adhere to national or international standards, and we will develop the solution with a clear roadmap, including clarity around funding required both now and in the future. Now, this approach and principles were agreed at a December shared care record workshop, which was attended by stakeholders across the system, and we will continue to work with that group to co-develop this solution with the community. And in fact, I think we have a follow-up from that session to play back some of the outputs in the coming weeks. And do reach out, if any of you would like to be involved in that, do reach out to myself and the team, because we're always open to, you know, the engagement there. So, whilst we are further forward in our efforts across the priorities that I really briefly touched on, there's still much to achieve to make our care records more useful and usable. I was moved by the stories from yesterday. I think we all were. Shane's story and Emma's experience is a reminder that our goal stands true. It is our why we do what we do, why we have taken time out of our busy schedules to be here. And we need to continue to come together as a community to collaborate and co-develop, most importantly, a solution that gets us sharing information to support the needs of each and every person and profession. And I'd just like to close on some of my reflections from yesterday. So I was definitely listening to the comments, and something that I'll take away to the national teams is your ask for more transparency, greater engagement and collaboration, and better communication. And also, there were lots of questions yesterday around the interoperability and the solution that I've talked about, but also the legislation. And whilst we've consulted heavily on the legislation, I think there's a big aspect of it, especially around the standards operating model, that I think we could do better in terms of raising awareness. So look out for 2 further engagement sessions in the coming weeks, and the team will promote some of that, but we'd really like to get you engaged and involved so that we can raise awareness about, you know, the legislation gives us the power to use open standards and to mandate information standards to support sharing. But what does that mean for the suppliers, and what does that mean for the providers in terms of unblocking some of the challenges that you've quite rightly raised? Thank you.
So we are ahead of time. Do we have any questions? You can't run off the stage, Manal. Well, you can do. You know, so we have got a few minutes. So do we have any questions? Come on, it's tumbleweed moment.
Is that Gary? Yeah.
Hello, I'm Gary McAllister, the Chief Technology Officer for London.
Hello, Gary.
Hello. I think there's a few key deliverables now that I think this group would really, and Lee mentioned it at the start, but in the formulation of the plan moving forward, getting a national information sharing agreement which covers all the health and care sectors and makes it far easier for information to be shared, I think is critical. And I'm not quite sure where the IG support is coming from in the centre to allow that to happen, but there's a lot of unnecessary time and waste spent across all these programmes and trying to make that work far more seamless than what it is today. Alongside that, it's really nice to hear that, you know, we're going to kind of pass the baton on international standards. I think that's really important, and the profiles to support some of the journeys on the screen. But I suppose the question is, with the limited funding available to us at this point, what would be the priorities from the centre in order to get us moving forwards at pace, certainly with the border issues that we have?
So I think, so clinical governance and governance as in general is something that's repeatedly come up at our National Programme Directors Group, actually, and there is a big gap there that we need to fill. So I think we're setting up a governance group because there's definitely more that the centre can do around easing some of that burden, because we are told by our community that is probably one of the greatest barriers within systems. And in terms of what we can do to take this forward, I think, well, firstly, there are a number of groups that have been set up with a view to engage with our system providers. We agree that you're the best people to make those decisions. You're the best people to understand where you are in that journey. When I talk about that twin track and we look at all the 42 systems, they are, quite sporadic in where they are in that continuum. So we need to make sure that the solution works for each and every one of you. And part of the work that Gary and I have initiated, which will be played back, is how each and every one of you sort of join up the dots and meet us on that journey wherever you are now. So I think what I would ask from you is to engage with us, to definitely reach out if there's anything that where you may require tailored support for your area. And sort of bring forward some of the local challenges and barriers so that we can work through those. We have we've pulled together a really comprehensive business case, which I hope will go through our internal approvals over the next few weeks. And that's a really big message, actually, because that shows the importance that the centre are taking on interoperability. So in terms of, I don't just come, Gary and I, we've talked about the architecture, we've talked about legislation, but the legislation absolutely requires shared care record infrastructure to be in place. Without it, we cannot implement the standards. So that's a very big part. So yeah, look out for further information. But my ask would just be to get in touch with the team if there's anything specific to your region that we can support with. Thank you.
Ian Anderson, the Hull City Council. I think one of the dangers is when we talk about health and care is there's an assumption that that's the only environment we're looking at. In local government world, obviously there are a number of people who fall outside the statutory care provision that are relevant to this journey, and in particular if we look at the programmes like the Changing Futures programme that is within DLUC, they are dealing with people, many of whom have a significant impact on the health system, because the homeless people on the streets have a very significant impact on A&E, largely through things such as access to treatment, because they're not necessarily registered with GPs, and the fact that attendance in A&E does not resolve the issues for them, so that they may, for example, repeatedly turn up every day or every week for dental treatment, but not get dental treatment, just get an alleviation rather than dealing with the issues. So I think what I'd say when we're talking about sharing between health and care, we need to look at that broader picture, because there's so often a focus on just the adult social care environment, which is the liquid logic type of world we look at. And so one of the things I'm very much looking at the moment is how we bring through the fire gateway other sources of information that will have a real significant impact on health-related costs. But the other element as a plea is research and medical examiners is two areas I've touched upon. But research data sharing is not sufficiently in a strong place, I think. And what we find is that many research organisations find themselves having to work through the challenge of how to get to a data sharing environment. So I think, again, it's a much broader picture. If we just focus at health and care, we miss a trick.
Agreed. It's definitely a journey, and as I mentioned, the programme started to share information between acutes and general practice. The level 2 really does expand on that, and we don't expect to stop there. But it's very much a journey, and hopefully together we'll get there.
Okay, we've got time for one more question. We may not have time for one more question.
Coming from a family of 8, I could have shouted actually for Rome City. So we've done a terrific amount of work. I'm Jane Owens from Joined Up Care, Derbyshire, now. We've done a terrific amount of work on shared care records, but there is one thing that I think we're not concentrating on at the moment. that needs a lot more investigation, and that is the usability of the systems and the amount of places that information is now held, making it very, very difficult for the clinician or the social care professional to understand where the information is that they're looking for and to be able to access it in a timely fashion. So I think, my plea there is for all clinicians and healthcare professionals is that we look to try and minimise the amount of systems that are holding the information so that we are basically giving them a bit more power back, because as it stands at the moment, we're in danger of them turning away and not bothering to look because they can't find it.
Yeah, I agree, and a really good point there. And I forgot to mention that the team ran a really successful clinical workshop where we had multidisciplinary teams just a few weeks ago, led by Phil, Leah, and members of my team in Leeds, where we looked at exactly that, the usability and what information is required for each of those disciplines to make the system more usable. So there's a lot that we are doing, but there's a lot that we need to continue to do to make sure that, like I said, the shared care records are useful, usable, and used. Yeah.
Okay. So thank you for all them questions. Thank you for the presentation,
Dan, thank you.
Manel. And I think to summarise, I think there's probably a couple of points before we'll let everybody escape to the first session. We know times are tight and we know money's tight. But under the Chancellor's announcement, there's a lot of funding that's linked to productivity. Now, this needs to give real productivity gains. Shared care records are the glue that share that information, if it's actionable information together. So although there might not be specific linkage to shared care records, the reality is there is massive opportunities to use joining information up, shared care planning, slicking information, dealing with the issues that Jane has suggested as well, because it needs to be a good experience and be usable. So I think we shouldn't look to be in the poor relations. I think our opportunity is to build our value proposition and business case, and we do have some time for doing that, probably one for the end of the day. And the other bit where we probably need to come together is how we utilise other assets. Now, I know Gary said he wasn't going to mention that two-letter acronym, but certain shared care records and technologies are already using AI with large language models and cognitive AI to present data that's appropriate to their practitioners, international, and even proof of concept work happening in the UK on that one. And that could solve some of the issues as well of making the information go into the right place and be more presentable. As an example, so there's probably something we can do around knowing that the problems are out there and what possible solutions can we start thinking of now that we could then enact in a year or two's time. So again, I think, thank you very much for the presentation. So let's show our appreciation before we leave the room. And if we just wrap up now, and if you want to go to the room of your choice or stay in this particular room, that'll be brilliant. See you all later.
Don't know how many's left. Yeah, perfect. It's great. Okay, hi everybody. If you want to grab some seats, we'll get kicked off on this session. You'll notice we are slightly light on the attendees today, but we have Jason and David with us to go through their experiences through emerging opportunities. I'm Laura Gottschalk. I'm hosting the auditorium today on both sessions, so I'm introducing everybody and closing the sessions as well. So just to introduce our panel today, so we have David Grigsby, who is the Chief Business Development Officer at GravNet and Docabo, and prior to that he was Liquid Logic for 20 years, including 11 as the Managing Director, so he's got a keen interest in health and social care integration. In his spare time, David likes to learn bass guitar, interesting, and enjoys live music, and this week he's going to 3 gigs and a musical, which he said is bad planning, but I think that's actually quite efficient, so get it all done in one go. And Jason Young as well today. So Jason's the Assistant Director of Digital Transformation at Bath and North East Somerset, Swindon and Wiltshire ICB. The Share Care record for BSW forms part of his portfolio. Jason's just got back from New Zealand at the weekend before this conference and is still very jet lagged, so please go easy on him in the Q&A session at the end. Actually appreciates all questions to be asked slowly and avoid any complicated words, please. That would be great. So I'm going to hand over to Jason first, and then I'll be back later.
Morning, everybody. Yes, so I appreciate that I will be talking quite slowly, and it's about, it's felt like 3 a.m. for about a fortnight for me now, frankly. Yeah, sympathy if possible. So I'm going to be taking you through our experiences of care planning. The principle of this session was where you go beyond shared care records, what else you can look at. The Emerging Opportunities was the title, and in BSW, as I've introduced, Bath and North East Somerset, Swindon and Wiltshire, we've taken care planning as one of those areas where we see as a real opportunity to build on our shared care record platform. So first slide here is the usual geography lesson. We're on the edge of the southwest. I'm sure a lot of you have been to Bath and probably had a lovely time. I'm sure fewer of you have been to Swindon, and I imagine even fewer again have been to Swindon twice. But both those cities are in my patch. We're about 1 million people, not the most complicated, but not the most simple healthcare setting as well. We've got 3 acutes, we've got 3 local authorities, 3 community providers, and you can probably guess we are the result of a merge of 3 former localities, 3 CCGs, to get where we are. When I put these slides together, I thought I was going to really enjoy taking you through the beauty of a Sankey diagram. Obviously, I feel rotten, so this is going to be a bit complicated for me as well as for you potentially. But what I'm trying to show you there, and I'll turn around so I can see it better. On the left, we have got our partners for the integrated care record in BSW, and on the right, we've got what they're looking at. So, as an example, Great Western Hospitals, one of our acutes in delightful Swindon, look at GP records more than they look at anything else in the shared care record. And you can see that big swooping peach line at the top there. And you can see the next swooping line down is care plans. You can see that they're a big user of what we're talking about here today. And then you can see that they look at lots of other things as well. The smaller fine lines go to all the other bits of the shared care record that we provide. If you take the example at the bottom, you've got general practice, look at GP information as well, which is odd because that's where it comes from, but that's what we found they do. They're a big fan of looking at acute information, and they also look at care plans. So whilst data from the GP record is the most popular part of the ICR, our integrated care record, when I'm talking about these emerging opportunities and care planning being one of these, this isn't an edge case. This isn't something that we're doing in the corners there. It's the third biggest thing of our shared care record in terms of hit rates. This is a single month, and you can see each of those numbers on that slide is an individual point of care where a professional has, for whatever reason, needed to look at a bit of the shared care record in order to support the individual that they're working with. And also, if you look at all those finer lines where you've got small levels of activity moving from a smaller organisation to a less popular part of the share care record, if you stare long enough, you can actually see the face of a Nuri Bevin emerge in front of you. So Dave is going to give you a little walk through what the GraphNet solution that we use in BSW looks like in terms of care planning a bit later. So I won't dwell on the screenshots, other to say that what you're looking at on the left is the landing page in terms of the care planning functionality. So you've got EPACs at the top right, and you've got Respect with the purple shading there. And when I talk about care plans in BSW, I mean Respect and I mean EPACs. That's where we've had our success, and that's where we're focusing our efforts currently. So for those of you not in the know, Respect is the process that creates personalised recommendations for a person's clinical care, and the key bit of information within that Respect is the do not attempt resuscitation information. So in a crash crisis emergency, that's where that piece of information will be kept. Historically or in paper systems, that will be on a very easy to find purple form that will tell those responders what that person's wishes are. EPACs means to capture and share information from people's discussions about their care. So it's wider. There's more facets to EPACs than is captured within the two-pager that is Respect. And crucially, you've got there that the aim is to ensure that any professional involved in that person's care has access to the most up-to-date information. Well, I mean, fundamentally, that's why it forms part of our integrated care record programme. It's about getting information to the right people at the right time to support a person's care. Another one of these, I love a Sankey in normal times. So this is showing who is looking at our end-of-life care plan, our EPACs, and who is looking at Respect. So you can see the acutes are the biggies. They're absolutely geared up to this. So Great Western and RUH are the acutes in the 2 of our 3 localities where we've rolled out our care planning solution. And then general practice are beginning to get involved in a month, just shy of 1,000 views of people's care plans and Respect forms. But what's important is that we've not just got our 2 usual candidates of general practice and the acutes involved. So hospices, who are obviously quite small organisations, you can see feature a little bit bigger there. We've got Prospect Hospice and Dorothy House Hospice. We've a third one in BSW that is shortly to get involved as we roll out to our 3rd locality. And as you would expect, end of life forms a big part of what they're viewing on the shared care record, and it's really brought them into a partnership and how we can work with our non-traditional NHS and social care partners to be able to support them on the care that they give. Also, a final point on the right-hand side is about out-of-hours views, which I think you'll find listed under MedVivo. Yeah, there you go, 213 in that month we're showing here. So this is where we can start influence change in behaviour. So when there is a call to out of hours, this is the most likely scenario where somebody's previously agreed care plan isn't going to be followed, not due to poor care, but due to when information isn't available to those responding out of hours. So the fact that you've got these is now significant proportion of out of hours activity in the shared care record is looking at these care plans, and are not insignificant numbers happening in a month. We can now see that they are making decisions in these crisis moments informed by the plans that individuals have put together. We heard yesterday, I was present for all 4 of the people's stories, the patient stories, that remind us why we do what we do. And I'll take a brief diversion to relay one that an end-of-life consultant who works on this with me shared about an individual who lived in a care home, had made the decision as she approached end of life that it was in her best interest to die in the care home, and didn't want to have a traumatic experience with hospitals in her final days. But when her condition worsened, naturally this was out of hours, and a crisis team was responding to that with the care home thinking an ambulance was the right thing to do. Now, ambulance don't have access to our ICR, our integrated care record, but fortunately, as part of the crisis team, our community services got there before the ambulance call was made, and were able to share the care plan with the care home staff, were able to reassure them and the individual's son that this situation had been foreseen as best as these situations can be predicted, and staying in the care home was the right choice. Now, this happened in December. We all know what December is like in the NHS, and that individual, I'm told, was able to die in her place of residence, listening to her favourite Frank Sinatra music, as a contrast to dying in a hospital car park in an ambulance. And whilst the speakers yesterday do a much better job of reminding us all why we do it, the actual impact of how we can care for our population, those that we're responsible for, from making this information available, is coming back to us in BSW from these stories, if you like, from the front line. So that's really good. I mean, it obviously isn't good when someone dies, but it's really good when you can help them have a good death. I will dwell a bit on the less good, and I did warn David this was coming. So in 2021, we started work with GraphNet on shared care plans, planning that work, and then on Respect. And my CCIO, Shan Mantri, had this fantastic idea about sharing care plans and Respect via the NRL, so our ambulance service would be able to access this. 6 months piece of work, end-of-life consultants really enthusiastic. I don't know if you recognise the lady from the Titanic at the bottom. We're still waiting, David. Still would love a go-live date. Yeah, we're 3 years down the line now, and we are, we might be in the middle of the pack of people going live with NRL, where we'd hope to be pretty soon in that journey. So that is frustrating. We've burnt capital with the people that we're working with around. We want to get ambulance involved. Ambulance are obviously a key partner, and we're not there yet. The closest we've got is out of hours, as I just mentioned. But what we have been doing in that time, looking at that timeline, which I can't read on the slide here, so I have to turn around, we started with a frailty pilot back in January 2022. That is the last time you'll hear me mention frailty, because it ended pretty much the same time it started. Double entry from the clinicians, absolutely ruled out from the get-go. There wasn't the buy-in, and we all decided to end as friends rather than continuing on that path. So it was with some low expectation. A couple of months later, we started the end-of-life project, just in our Swindon locality. Again, as a pilot in terms of what are we going to encounter, and is there a way around it? And we didn't have the same experience as we did with frailty. So, what's that? 5 months later, we had our first 100 care plans live on the integrated care record and being viewed in that one locality. So that next year, is the care plan work going well. We moved to Respect, expecting similar to happen. And as you can see on the right-hand side, in between those two events, we had an ICR outage. Now, I don't put that up there to say that, oh, GraphNet's always down. It's not. Yeah, I'm sure you all have your own share care records that have their moments of hair pulling and frustration. It's down for a bit. It came back up again. We did our usual P1 response to sorting that. And in pulling these slides together, went through what happened at the time. Care planning being unavailable wasn't mentioned at that point. We only had 100. It wasn't considered. You'll be able to work out probably by looking at the rest of the timeline why I mentioned that. So you can see with Digital Respect, starting in May, 2 months later, we had 1,700 of these. Now, whilst we started with low expectations, this was amazing in terms of a response. We were really pushing an open door in terms of clinicians wanting to embrace a digital way of working, wanting to embrace Respect as a way that they supported their patients. And yeah, we were overwhelmed with the volume that we were getting in what was now our Bath and North East Somerset locality, Baines, and Swindon, so in 2 of the 3. And then we had another ICR outage, so sort of 1 a year, down for a few hours, at which point our palliative care consultant team were, wait a minute guys, what's going on? We rely on this. This has become mission critical for how we deliver care. We've got, it probably wasn't 1,727 at that particular time, but we've got thousands of these things and we can't access them. So what that led us to was a different way of thinking in terms of how we manage business continuity. We needed to have plans to be able to support a system that where things like this are going to happen. Not just outage, we have planned downtime for when we do upgrades, and as I'm sure you all do. And we then unfortunately went into a period where System C, who provide the EPR to one of our acutes GWH meant that care plans couldn't be viewed there at all for a couple of months. And I'm sure you've all got similar tales to tell for when brown stuff starts hitting fans. But that was a really difficult period of where you've taken a clinical team on a pathway of working differently, and they're then unable to do so because the technology isn't enabling them to do that. But we got past that through the usual working with both GraphNet and System C, and rolling out the contingency plans that we'd put in place for the outage that we'd had previously. So that gets us to the end of last calendar year, where we then got up to 5,500 respect, and just a reminder about the EPACs as well. When we were in February, we had 1,500 of these. So I opened with this isn't a sort of an edge case that we're looking at with the shared care records, and we're now only in 2 of our 3 localities, but with significant numbers of these that are evidenced both by the qualitative stories that we're getting back about the changes that they're making to patient care, but also by when we take it away. Admittedly, we didn't want to take it away, but when we did take it away, how the services reacted to not being able to access this information. So, we've learnt a bit over those last few years working on this, and clinically led is a phrase that is always used in terms of how you get buy-in for a digital project, and we had that in place for Frailty, the project I said I wasn't going to mention again, and it wasn't enough. Clinical leadership is key, but what we found made the difference with the end-of-life work was clinical delivery. So we had a palliative care consultant, and we had a member of our team on the payroll, if you like. Obviously not full-time, we're not crazy rich, but we had dedicated some of their job plan to not just provide the leadership to this, but to actually be the boots on the ground, that when you've got a member of their peers saying, but what about X, Y, Z? Or there wasn't as much of an argument around double entry, but there was a discussion around double entry at one point. They weren't having a conversation with somebody who was trying to understand where they were coming from. They were speaking to somebody who worked on their ward, who walked in their shoes, who delivers the care that they're trying to care. You've got a doctor talking to doctor relationship about, well, I filled one of these in yesterday and this is what I did. And that's been absolutely invaluable to us. They provide the leadership, and they are part of the shared care record extended team, if you like. But they're also caring for patients day in, day out, and are dedicated to the rollout of these care plans based on the fact that they've got the relationships with the people they work with, they have the understanding of the patient pathway. You've not got somebody needing to come in and process map a to-be process and interview everybody around, because you've got somebody who already delivers the process map. And that has delivered us into a more less of a digital, we're rolling out that piece of paper electronically that you all wanted, guys, and more about able to deliver the change program with digital in the shadows, if you like, just making sure that the tech works largely. And the next point on that list, you can see, it was a change process. A lot of the challenge is a stronger word, a lot of the questions and the queries and the support that was required in the rollout wasn't about how do you make the technology work, but it was about how do we deliver care in response to what we're putting in this care plan. If so-and-so has said this, and now I've got an update to make, what does that mean I should be putting in? Those aren't questions for a digital project manager. Those are questions that need to be thought at for those responsible for delivering end-of-life care, either on a strategic level or a policy level or an outright clinical setting. And so we had the right people in the team to be able to answer those questions, because they were coming up against those issues themselves, with the outcome of it wasn't just this is how you do it type support that we were putting out there for completing digital respect, if you like. Our palliative care consultant was able to write policy around end-of-life care that incorporated completing digital forms, as opposed to it being completely separate. I made the point about business continuity plans. Everything breaks, and you need to have a plan for when it doesn't work. Yes, that's easy to say, and those business continuity plans improve every time they get tested. But it's absolutely critical to go into each iteration, each go live, each new version with when something we haven't predicted happens, and it will, what are we going to do about it? And that's something that our clinical colleagues were quite blind to, I think it's fair to say, and that's where digital did really need to step up and explain that you just can't expect 100% uptime. You can't expect us to capture everything in testing, and we need to understand the impact on the clinical teams and broadcast that and be open with people about it. The point around formats and the user interface, I probably have always known that everyone's got an opinion on how a form looks like. The key bit is everyone's entitled to their opinion, but you need to have a way of having a decision made, because you can argue about whether the box should be on the left or on the right for months, and people seem quite willing to come to meetings to do that, which has always bewildered me. Ultimately, what is that phrase? Don't let good enough don't let perfect get in the way of good enough. We're very much a believer of good enough in BSW, and I'm proud to say it. I don't care where the bloody box goes, just make sure it's the right box and we'll move on. Governance. So I mentioned about policy that was actually clinical policy that referenced digital that we encountered we needed forming. You can't just, as you all know, you can't just write a policy and say, there you go, that's the answer. There needs to be a decision-making process, but then there needs to be a formal decision-making process. And really early doors, we got our end-of-life alliance, as they were called, so the board that was responsible for end-of-life across BSW ICS, to formally own, we're rolling out respect and end-of-life care plans digitally. Aren't we? Yes. You're happy that we're doing this? Yes. Okay, we'll come back and we'll let you know what you need to think about. And that's been fantastic. So where at any point there is debate on approach or issues wider than digital, you have got that backup of, if someone's saying, well, who says so? The ICS, all of the partners say so, because we've gone through that route. For something that could be quite minor, having that ownership by senior leadership within each of the provider organisations has been the reason why you've got such big numbers across the two acutes that we showed about. So difficult to get at the outset, but once people have understood why you're bringing it in, that's been a real favour for us in terms of being able to move through some of those conversations and delegate some of that opinion making about whether the box is on the left or the right. So that's me, and that's BSW. I hope that was vaguely interesting for your Wednesday morning. I'm going to hand over to David now for more stuff in this vein.
Thank you, Jason. I don't know if people know, but we were supposed to have two more speakers, some colleagues from Wales and also Evelyn from Kent, who I'm sort of standing in for. So Jason was only supposed to take 5 minutes, so you did a really good job of spinning that one out, and it was all very interesting and practical. Thank you very much, Jason. It's nice to be here today. I was discussing with a colleague the fact that a colleague who's going to Venice tomorrow, the fact that Birmingham has more canals than Venice does. So what better place to be than Birmingham this morning? I will be standing in for Evelyn, who sadly can't be with us today. So please bear with me as I try and take you through her slides. It's never the easiest thing to cover somebody else's slides. Let me just make sure that they move on. There we go. So I'll be talking about the Kent Shared Care Record. and what they're doing with care plans. They implemented their solution with us at GraphNet in 2021, and it's a reasonably well developed shared care record now. And shared care records in themselves are very useful, as we know. I think they've proven themselves in the way that they enable clinicians and professionals to have a broader understanding of what is going on with the patient. They release efficiencies, and they are much more safe for the patient when people have all that information there. And Kent now, along with many ICBs, and you just heard from Jason there, are now trying to move to use the platform as a hub for more proactive care coordination, targeting cohorts of patients with certain conditions or risk who will benefit from targeted, more focused early support. And that's good for them, obviously improved outcomes for the patients, but good for the health and care system too, by managing their condition and reducing admissions, reducing GP face-to-face, etc. So really wanted to talk about, if you like, what's the next step for shared care records. And I think most places are beginning to do this anyway, so this is really a bit of background about Kent. But before I get into that, it's worth you seeing the underpinning record. You can see here the organisations that are consuming data, that the vast majority have got single sign-on from their core system into the record. And where you see red crosses, that means that they're not feeding data yet, but all of those red crosses, they're in the process of implementing that, and we're waiting for the organisations concerned to give us the interface or supply us the data. Data comes in a variety of ways. There's HL7 and 5 views in near real time or real time. For others, it's more basic data extracts that run regularly, and we ingest because that's what those third-party systems can manage. I'm sure you've all had to be pragmatic in how you get that data in. There's real-time views of GP data. However, whilst Kent can and do display that data, as I've said, in real time, they also ingest the data because they have a population health solution, as BSW do, behind the shared care record, and they reuse that data. And that's something I want to return to, the fact that shared care records are bringing in a lot of data, and there's great ways of reusing it in analysis. They use care planning and care coordination in the platform, and I'm going to cover in a moment with frailty as an example, actually. Jason, having said that they didn't pursue that at BSW, Kent have got that off the ground. I'm not quite sure why they managed where it was problematic for you, Jason. We can have a look at that one, perhaps. But it links back to the data being ingested, as that ingestion enables Kent to analyse the data and then identify the cohorts of people who would be considered as being vulnerable and frail, vulnerable to falls, and who merit inclusion in programmes to try and more carefully manage them. So for Kent, the population health solution behind the shared care record is able to push and publish dashboards in the shared care record that contain lists of patients who can be then enrolled on programmes and managed in that shared care record. So the two are intrinsically linked, and the analysis of that data, the publish of those dashboards, enables the shared care record to be used for direct care and a platform for coordinating care. And here you can see a little bit more detail about that care planning module. It comprises assessments as well as a care plan that is created in the system. For example, within the frailty module, you've got a cognition and nutrition assessment that make up that part of the system. In some cases, the forms are pre-populated or partly pre-populated, usually from aspects of the GP record. And in Kent, the forms like respect, same as Jason have, conform to PRSB standards and are accredited by PRSB and the Resus Council as well. But Kent have designed some of their own forms. So we have a mixture of standard templates that are off the shelf and ones that customers design themselves. I think the beauty of standard forms, things like Respect, is that there can't be any debate about what goes into a form because those sorts of debates can be endless, as I'm sure you've all experienced. You can see here different revisions of the form on the left. So you can easily go into the previous versions. You can see an audit trail of who did what, when, what's changed. And you can see where data has been added to the system and where it's been brought in from the source system. So in effect, you're combining existing data and data that's been entered in a logical and useful way. Another thing that we're progressing in the Northwest, not in Kent, but is also exposing those dashboards, those lists, those cohort lists of patients in systems like EMIS, so that GPs can see in their practice who's enrolled on a program in the shared care record, and then they can click in to that patient from within their GP system. So we're probably all familiar with single sign-on, context launched when within a patient's record from a GP system, but this is slightly different in that in this instance EMIS is showing a list of patients from that practice that are on a program, and then you can click in from there. Okay. Can do a lot of reporting in the system to assess utilization by organisation, as Jason was showing as well. It's useful so you can see who's utilising the system, who isn't. You can focus work on increasing it, take up. But that's not just at system level, not just at which organisation is accessing the system as a whole, but it goes down to the parts of the system that they're accessing, or the tiles that we call with our system. So here you can see which organisation are accessing the frailty tile, in this instance down on the right, and that enables them to sort of focus their take-up work. Kent have just been awarded quite a handsome sum of money from the HTAF fund, which I'm sure many of you will have also bid for, and their target for that money is to increase usage by 30%. But they're already doing pretty well. I think they've, I think it said on the first slide, but they've got 140,000 views a month, over 10,000 healthcare professionals in Kent accessing each month. So there's pretty good take-up there that they've achieved in a relatively short space of time. Here you can just see more analysis of the e-forms being used and created. And they have got over 1,200 frailty forms now. So that has picked up steam quite well. And really, final slide from Evelyn, and I've got one more. I think their lessons learnt were very much the same as in BSW, that whilst you need good program project leadership, the IT needs to be on point and well led. If clinicians don't get behind it and lead it, it won't fly. So that was the clear lesson from the experience in Kent. And I think Respect is a good, Respect form end of life is a good place to start, particularly helpful for the ambulance service. And I think that some of the forms like Respect, because there isn't debate about them, because you use a nationally approved template, it cuts out quite a lot of the chatter around the project and can enable it to move quickly. But we've got other examples up and down the country in use, things like diabetes, heart failure, learning and disabilities assessment, maternity, are all examples of care plans in use in the system as ICBs extend the use of their shared care record beyond just viewing, but as a platform for care coordination. This isn't one of Evelyn's slides now, this is one of mine. But I just thought it was worth dwelling on. First of all, on the left, you can see the components that are typically in use with a shared care record. Shared care record is central, enables the viewing of data and brings in data. But that can populate an analytics platform, a population health solution, which can then identify groups of patients, cohorts of patients, who merit more focused work or early intervention work to improve their outcomes, but to save health and care system money. Those cohorts, as I've said, can be surfaced in the shared care record, which is a logical platform for coordinating programs that cut across organisations. They can be given care plans in the solution. They can access those plans themselves via a patient app and interact with them and with their professionals. And it might be, certainly in our case, that they're enrolled onto remote monitoring programs. Importantly, the effectiveness of those programs can be analysed again in the data in the population health solution, so you can really assess whether those early intervention, more targeted support efforts are worth the funding or not. And it's worth pointing out on the right there, just some stats from some of our customers. First one, 2% of patients in an ICB with a 2.5 million population represent 40% of bed days. And it's a similar familiar story across most ICBs. And I think that it's never really been questioned, has it? Every government, every healthcare professional, every talking head really talks about data being used to target resources more. And I think the ICBs were created in part to bring more coordination across different agencies, to pursue more proactive programs. And I think the shared care records that people at this conference are responsible for, are working on, are the perfect platforms at ICB level to manage those coordinated programs. And the data that shared care records bring in enables you to find, target, identify the people who would benefit from such programs. And we've had some great examples amongst our customer base. I think Frimley is speaking next. I don't know if there's anybody here from Frimley. But they've used the data that they initially ingested for their shared care record to identify cohorts of people with long-term conditions, comorbidities, or in high need groups who they felt would benefit from remote monitoring at home. And they've put them on remote monitoring programs. And then the data comes back in to the population health solution, and they can analyse the effectiveness of that program. And there's been some really startling results. They've managed to get about 8,000 people monitored, not focusing on virtual wards to reduce length of stay in hospitals, but focusing on people with long-term conditions and who are considered high risk. And importantly, when they identified the cohorts of people for those programs, they had a control group who could have been enrolled but weren't. And they've evidenced 40% reduction in hospital admissions, 30% reduction in GP face-to-face, 10% reduction in prescribing, and reductions in 111 calls, 999 calls. And it's a really good example of the shared record infrastructure, population health infrastructure being used for this cohort identification, early intervention, managed programs that are delivering results. But because they can evidence the results, the funding continues because it's seen as releasing capacity and worth investing in. And I know that can be the problem. It's very hard to get funding for new things when everybody's struggling to keep head above water. But I think we all know that the NHS is not going to have increased budgets to cope with increased demand. So it has to find new ways of working. And I think that the platform that shared care records provide and the data that they can hold if you choose to ingest the data provides a great opportunity for data-driven, targeted work with cohorts of people for whom, if you intervene early, you have better outcomes for them and you save money for the health and care system. And I think that that's got to be the way forward for these brilliant shared care records that are now maturing really well. And I'm going to end by stealing a quote that Frimley themselves use. It's actually from Desmond Tutu. And he said, there comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they are falling in. Now, I don't think he was talking about the NHS when he said that, but it rings true, doesn't it? And I think this is part of what the ICBs were set up to do, and I think that what we all do provides a key bit of infrastructure to enable that. And I think that's the next step for shared care records. And I think we've got 10 minutes left. So if anybody's got any questions or comments, please fire away.
Fabulous. Thank you so much. They were absolutely brilliant examples there of some brilliant work that's going on around the country. Does anybody have any questions? We've got about sort of 10 minutes or so left. Oh, yeah, we've got one up there. I can just about see you. It's incredibly bright. Thanks, John.
Hello, I'm Corey Osmaston from Gloucestershire ICB. I've got two questions, if that's okay, one for Jason and one for David. So, Jason, I wanted to ask about, you obviously you started off with frailty and then moved to end of life, your pilot. We also went for frailty in Gloucestershire, so I was wondering why you think that frailty didn't succeed and end of life did. Was my first, and then I just do my second one, which was for David. So I noticed in the kind of table showing the coverage of the shared care record that there's not full coverage, so not all the GPs are contributing, and there were some organisations that were only consuming. Where you're doing cohort identification, is there a risk that some patients are missed off those cohort lists because the data about them isn't in the shared care record, and then they kind of fall through the cracks? And if so, how do you manage that? I think because that cohort identification is also something we're really interested in. Yeah. Thank you.
This is on, that's good. Hi, Corey. I think you're out there. It is remarkably bright up here. I was amazed anybody was there at all, actually. So you asked about why frailty didn't work and end of life did. So we got pushback, as I mentioned, on double entry. So people who currently recorded information that would have gone into a care plan in TPP for either community or GP, although it was largely community we got the pushback from. And that was both in both projects. The mitigation that was suggested for both projects was the information is still available to you if you put it in the shared care record, so you don't need to duplicate entry. And there was, let's call it policy support, there was approval that you could write CICR in your host record, and then you'd be able to access the information that previously you would have put in TPP. Now what was interesting was with frailty, that wasn't deemed a sufficient solution, and with end of life, it was acceptable. And I think a lot of that goes down to the clinical leadership and buy-in, where the palliative care team were able to drive that through, make it happen, and then be talking from a point of, well, we've got all these care plans already, and everybody else is doing it, so jump on. Where with frailty, we were starting from a point of, we can't get any because we've got this double entry issue. So same solution provided for both. I think there was a mix of personality and the level of clinical leadership that we were able to get for the frailty project. We didn't have those dedicated clinicians that I referenced that we've got for palliative care. We didn't have people on staff, if you see what I mean.
Yeah, and to answer your question, well spotted on that. I've just had a look myself. I think the gaps in data being fed at the moment, with GPs, it's just 3 GP federations. The other gaps are hospices and out of hours, which are coming on, all of those are coming on stream soon. If I'm being honest, I don't know the view that Kent took to the fact that they had some missing data when it came to cohort identification. all I can say is with other customers, where they've identified cohorts, they haven't always been able to put them all on programs anyway, just to, shortage of funds, there's only so much you can do. So I'm not quite sure how they prioritised who was put on those programs and who wasn't, I'm afraid. But it tends only to be a subset of the whole cohort anyway.
I'll jump in and add, again, not being from Kent, but top left does describe that all practices are sending data. So the federations, it would be the services that the GP Federation provide, which, while still important, it's not going to be the same as missing John Smith with his diagnosis of dementia, because that would still come from the GP that was sending. It's just they would be a member of a federation, and then the extended hours service that might be provided, that data isn't included from those three that's missing. It is an interpretation one could apply to somebody else's slides.
Thanks, Jess.
Fab, thank you. I think we've probably got time for another, maybe one or two.
Thank you. Hi, Jason. Leslie Kitchen, Chester and Merseyside. Hello. So I'm really reflecting on what you talked about in terms of clinical delivery, and we're relatively complicated provider mix in our patch, and so that clinical delivery on the ground, on the boots on the ground that you talked about is probably really something for me to take away and think about. I also wondered when, and it's kind of on the why did frailty not work and what end of life did, are you getting a pull from your customer base, for want of a better word, for different services coming to you saying, we think there's an opportunity, can you help us with some technology around this? Or do you find that it's more of a, there's something that digital can offer here, go out and, I don't want to say sell the wares, but kind of promote somewhat. I know it's always a little bit chicken and egg, but is there anything that you use in terms of your local prioritisation processes that thinks about that clinical delivery aspect into whether or not something will go forward in future? Did that make any sense?
It does, yeah. It's a great question, because we have a mix of both. With end of life, we were dealing with some legacy solutions as we came out of the merge of the three CCGs, and it was a happy coincidence of finding Natasha, the palliative care consultant I've mentioned, at the same time as we were trying to decide, well, what are we going to do forward? So she didn't know she was coming for us. We sort of found each other, but she had an unmet need, a digitally unmet need, that we were able to say, well, let's test some options against it and then go from that. So whilst she and her organisation were then saying, yes, this is a problem that we're trying to solve, and you've provided a solution to that, that's not true across the whole ICS. So part of what her and her team of two are doing is then having to make that sales pitch that is either received as a, oh, thank goodness you've come, or yeah, tell me again. And so there's a definite different response to pickup, and that's why we've taken our localities in turn in the way that we've had. In other areas, we've found our third sector have been banging the drum for why are we excluded from the shared care record, and this year we are doing some work to get them access, and that was them very much coming to us. But we've still got one of our three local authorities who isn't sharing or viewing, and that is us very much going to them and going, oh, bloody hell, come on. It's been years now. So there is that mix, and that, as Leslie, as you know, there's that mix of skills in terms of you've got an enthusiast who wants everything, and then you need to sort of manage them into a deliverable scope if you can even deliver it at all, and then you've got those reluctant that take a different kind of management to get them onto the same page as everybody else. So yeah, it's probably a similar mixed bag that you're experiencing as well, and probably part of the frailty end of life issue, as you identified, that we had some champions. They weren't just doing the do, they were really flying the flag.
Brilliant, that's fab. I think we're going to have to pull it to a close there, just so everybody's got time to shift around and have a comfort break before the next session. But I'm sure if anybody has got questions for David or Jason, they will be up here for a few minutes anyway, if anybody wants to. The next session after this, Everybody give everybody a clap, obviously. It's been a fantastic session. Thank you very much, both of you. You're more than welcome to stay here for the next session, which is around changing platforms, if you're looking at moving or shifting about a bit. But there are obviously 2 other fantastic sessions in the other 2 rooms as well, one on care planning and another one on secondary uses. So yeah, please feel free to make your way to whichever session your heart desires. Thank you. Good stuff. It is bright, isn't it? It's a challenge. Brilliant. Thanks, everybody. Thank you for joining the Changing Platforms session. So we're actually going to start with asking you a couple of questions where you can pop your hands up in the air and we'll try to see you from here. But how many of you have a contract coming to an end in the next couple of years? From a share care records. Okay, there's quite a few hands. So the next question is, how many of you are confident that all the work you need to do to hit that date is going to be achieved? Oh no, no hands, but more laughs than hands, okay? Okay. And do you have the resource plan and enough time, do you think? If you think you do, put your hand up. Not a single hand. Wow. Okay, brilliant. Okay, so I'll introduce our panel that we have today to discuss through the different experiences they've got through changing platforms. So on the panel today we have Andrew Hall. He joined the NHS in 1992. After various director and CIO roles, he joined Notts Healthcare as Head of Health Informatics in October 2013. He retired in December 2019 so he could join the Nottinghamshire Integrated Care System to work initially on the strategy for data analytics, information and technology, and is now the Interoperability Share Care Record Programme Lead for the ICS. He's also the Programme Director for the development of the secure data environment for research for the East Midlands. Andrew has got 4 children. He loves cooking, reading, walking up hills, unusual. I'm more of a downhill person myself, preferably in the Lake District and preferably with the whole family. We also have Una Rice on the panel. She is so self-absorbed, her words not mine, that she's put a slide in the deck that's all about her, so she can do a bit more detail for you. She took what she believes is called a non-linear route into the NHS and digital and is now living the dream job as an Associate Director for Digital Transformation in Gloucestershire ICB. She's such a workaholic these days. Half her spare time is taken up with studying for her Masters in Digital Health Leadership. And then the bit that's left over is spent cycling in the Welsh Hills where she lives and kickboxing, which I don't know if you, well, hopefully not cycling and kickboxing at the same time. That is quite a skill. We also have Paul Cook, who is the Commercial Director for Synonetics, which, like Una, he says is his absolute dream role. He tells me he's worked on contracts from 116 trusts from Whitehaven to Truro and from Colwyn Bay to Great Yarmouth. Apart from NHS IT, his passion, which you probably may have heard of before, is food and cooking, and he's always up for a chat about ovens, ingredients or restaurants. So I will, we're going to go through now and each of them are going to do a bit of a presentation and then we'll open it up to Q&A as well. So if you'd like to come up, Andrew.
Hi, morning everyone. You're in the very bright light over there. So I thought I'd start with some A-level maths, just to see if anybody was hungover from the night before. But actually, while you're looking at that and wondering why on earth it's there, I thought I'd do a tiny bit of history. So in Nottinghamshire, we started interoperability work actually around 2017, where one of our local authorities did some fire-based work to find out if they could help the local acute trust determine who is the responsible counsel for that individual and do they have a existing social care package. And they put that in place successfully with one trust and then a second trust. And then there were other trusts becoming to be interested in that. Oddly enough, at the same time in 2017, we actually started using GraphNet in Nottinghamshire, with a 5-year contract glued onto a System C PAS contract, which we then subsequently extended in 2022 for another 3 years. So our contract end is November 2025. The reason I put that up is that a lot of our integration and interoperability work is point to point, and that progression goes up. 1 plus 2 is 3, and you can work out how it quickly goes 10, 15, 21 and becomes out of control. It's the sum of the first n integers, slightly modified to account for the fact that you can't talk to yourself if you're in the middle, or even at the side. So that was the two completely different starting places in that work. Later on, we started work on a strategy with a bit of help from Gartner, and they recognised that immediately and said that we need a number of different platforms that manage our interoperability. One, which we called our ecosystem platform. The second would be an Internet of Things platform to try to manage or control all the different devices that might end up in people's homes or on their wrists. And the third one will be a customer relationship platform, or something that was just for patients, and so on. So we got that. We got that approved during the first COVID year. But then we started to think about the end of the GraphNet contract and how we might migrate from what effectively was a second repository of data that already existed through to something, and I won't touch on all of those different capabilities, but we wanted it to be real time. We wanted to go and get the data rather than to restore it and have a second repository of that data. We wanted to try to stop using the MIG once GP Connect seemed to be safe, and there's a couple of bullet points there where some people said you're not going to be able to achieve that. One of them was no licenses, and the other one was driven and owned by the NHS. Now, I'm not going to talk about how we made the decision that we did. You can ask me about that afterwards. All I will say is that we did not go through what would traditionally be called a procurement. We managed to persuade our stakeholders that what we should do is to look at the best practice in the NHS using the first wave LICRAs and some other entities. So we talked to 6 or 7 shared care records around the country, and we effectively came up with a whole series of things that we thought we ought to be able to achieve. So you don't actually hear the term event-driven architecture much nowadays. I think there's a huge amount of fashion in terminology in the digital space. But certainly 2021, that was something that we ought to be achieving, which is that you should be able to subscribe to a change in a data entity and to be told about it when it's happened. The obvious example of that is I'm a social worker and I'm due to visit Andrew Hall at home today. Oh, he's not going to be there because he's actually in the ED. So don't waste the time of going to see him. No, we don't know how often that happens, because we don't capture that type of data routinely at the moment. Right at the bottom, like many ICSs, ICBs, we're kind of landlocked and surrounded by other entities which refer data into our acutes, and occasionally they go outside to others into South Yorkshire. So we began thinking about what we needed to do. In terms of what the important issues that we've faced in the last 2 years of this journey. We have been in planning and development mode. I've told a small lie at the top there. It says plan for sustainability. We didn't actually do that. We discovered that, we're not recording this, are we? We discovered that the attention span of most NHS finance directors typically lasts just to the next year and not beyond. So if you don't need any money for the next 2 years, they're very happy to sign off with whatever it is you want to achieve until you reach the waterfall period where you've run out of money. So we didn't do that, but one of the things that we were extremely lucky in having is a business analyst and a technical architect who'd worked on that initial implementation of fire-based messaging, so that when we asked all of our data providers in the trusts and the councils to learn these new techniques, they had a friendly face and persons to actually bring them onwards on that journey. And frankly, if you don't do that, you probably end up spending 200 to 400 grand of professional services from an outside body. We had a better experience of doing it the way that we did. So that's probably, I've not been looking at the time, and you're not throwing me off yet, but I think that's roughly what I wanted to say, except some of my team are here today. I think I've been incredibly lucky in being able to build a team from secondees and stealing them from other people that already existed. So actually very few new people had to join this activity and understand what on earth the politics were in our locality. And I think the other thing I've forgotten to mention, and I should have put it on the slides, is that we created a digital charter with a series of principles, which is hanging off digitalnots.nhs.uk. It's not particularly easy to find, and no, I didn't write the website, so apologies if it's not immediately obvious. And the only other thing I thought I'd throw up is for one of our trusts, this is the rough integration that they've had to put in place in order to deal with a fire-based repository on their prem. So by having it on their prem, that is the thing that is queried by the shared care record and avoids the duplication of data. But because everyone starts in a different position, the work that they have to do can be a bit unique. So they had an in-house home-built system for producing clinical letters, which they wanted to retain. So they managed to stick a Fire API in front of that so that it can deposit those important clinical correspondence items into the repository so they're visible onwards. Okay. Shall I press on?
Hello. Let's see what happens here when I press the button. Thank you. So I thought I'd start with a bit about me. I'm sharing the stage with two people that have a length and a breadth of experience that made me feel like I needed to justify being here. So that's it wasn't just being self-absorbed. I've been working in the NHS on and off for 14 years, and I started my career in shared care records in 2010 in Oxfordshire with embryonic Oxfordshire care summary at the time that we thought we'd try and roll out alongside summary care record as it was going out first time. I have worked around integration and information sharing in that time, because we looked at even working in the out-of-hours service and 111 services. Integration and information sharing is very much part of those services. So I've been knocking on the door of this subject ever since. In 2014, I came to Gloucestershire. Actually, when I was preparing this slide, I realised that it's my 10th anniversary in Gloucestershire in 2 weeks' time. So, colleagues in the audience, let's have a party. in a lot of those cases, it's been about starting with, from the very beginning, with, with a vision, with no governance or structure, and taking it all the way through to delivery, which is what we did in Gloucestershire, starting 10 years ago. I thought it was important to give a little bit of context. Delivering a shared care record in Gloucestershire is not the same as delivering it for London or Manchester, or, our ICSs do vary. So Gloucestershire, hopefully you can get from the pictures, is pretty rural, reasonably affluent, not what you'd call ethnically diverse, and relatively straightforward in terms of its structure. We have two trusts, a local authority and an ICB that are coterminous. And I'm sure for some of you who have more complicated ICSs, that sounds like it should be really simple. It isn't necessarily the case. One of our big challenges is the borders. We've got quite a long border there with a lot of different other ICSs, plus an international border when it comes to healthcare in terms of Wales. So that in terms of shared care records is one of our significant challenges. So our shared care record, as I said, started in 2014. It takes a long old time to get going with a shared care record when you're starting from zero. On the left of this slide is our journey through our first shared care record. So through to going live in sort of 2017, 2018, and building and developing, and in the last couple of years coming to the end of that initial contract. Our first shared care record was with a company called Canos. It was a development partnership. We took an existing platform that they had and turned it into a shared care record, something we're quite proud of. We feel like it was a successful product. I've drawn a grey line there to represent COVID, because in terms of our shared care record journey, it had a fairly significant impact in that a lot of our team were redeployed to other priorities at the time, and also it was round about the time we should have been writing business cases and engaging boards and having discussions about what next. And that, as you can imagine, was quite hard to get anybody's attention on the subject for about 18 months. So it did set us back a little bit in timescales, and to Andrew's point, which he made there as well, is you need to start early. You need to be thinking about sustainability. You need to be thinking about your next shared care record now, no matter where you are on that journey. And that COVID did have quite an impact on us from that point of view. What it did mean is that we had to make some quick decisions in a shorter space of time, which does focus minds. So it probably supported speedy decision making and forced a bit of decisiveness, but it probably didn't give us the time to have the depth of conversation that you need to have if you're thinking of doing something different. Our board, however, did express a preference to move away from our sort of bespoke development format to a more standardised model. So unlike Andrew, we did go out to procurement, and we are in the process of implementing with Orion at the moment. Now, because, as Laura mentioned, I am a bit self-absorbed, I'm going back to talking about me for a minute. As Laura mentioned in my introduction, I am doing a Master's in Digital Health Leadership at the moment, and the topic of my dissertation is the one on the screen there. It's about ICS data strategy and shared care records, and it does link to Andrew's point about sustainability as well. It's really hard to make the case financially and return on investment in shared care records, and then there are all these other asks on us in relation to data strategy for different purposes and regional secure data environments and federated data platforms. How does it all fit together when you're a relatively small and simple ICS, and how do you make it affordable in the long term? So my pitch is I'm about to send out a Freedom of Information request and a survey to lots of you and your leadership team. So please lobby for completion of those. There is very little published research in the area of shared care records, so I'm going to try and do my bit to get something out there. A shout out to One London, who did publish a paper recently, and it's probably the first and most comprehensive I've seen, so good on them. So lastly, and I think we're probably going to discuss some of these are my few top tips. So I mentioned the first one already. No matter where you are in the cycle of your shared care record, think about what you're going to do next. I mean, we're not quite implemented with Orion, and we're already starting to think about where are we going to be in 5 years' time with our shared care record. Second thing is, and I don't think we do this well enough across, I don't think nationally we're doing it, I don't think across the whole cohort of shared care records we're doing this. Being really clear on what is a shared care record, first of all, and what is it not? What's its purpose? What use case is it solving, and what use cases is it not solving and you need something else for? And the other one is being clear on your EPR strategy and being engaged with providers around their EPR strategy, because the shared care record is only as good as the contributing systems. And if they don't have integration and interoperability capability, you spend a lot of time banging your head against a brick wall. And my last one is, shared care records are like EPRs. They're big, complex, and difficult to implement. And once you've implemented it, the thought of changing is one to make. And I have known colleagues in the past who've said if they had to do it, they'd move off and find another job. It's tough. And so I suppose I'm going to add a question to Laura's question earlier. How many of you are thinking that the best option might be to stick with what you've got because the cost of change is too great and the prospect of change is too great? I suspect a lot of people in the shared care record space are thinking like that. So if you are planning to change, you need to make sure the motivation is high and you've got the leadership and the buy-in to make it happen. And on that note, I am going to pause and let Paul take over. Thank you.
Green is forward, yeah. Hi, everybody. I think this has been a really, really good event. And I suspected I was going to have a good event because I've become quite superstitious, I find, as I get older. And on Monday afternoon at 4 o'clock, I had my second dose of MMR. My wife works in a school, and the Midlands has become a bit of a hot spot for measles, and I think you've sort of seen it reported in the press. So we were advised to go and have MMR. And I did that thing that, although I was going to be away for 2 days and I had to bring stands and brochures and chocolates and all of this stuff, I also knew that the doctor's only 10 minutes up the road, so I ended up doodling around, and then suddenly was right up against it. So dashed out into my hallway, picked up my bags, picked up the brochures, everything I had, jumped in the car, started the car, and then had this little nagging doubt in the back of my mind that the pop-up stand bag seemed extraordinarily light. And so I twigged suddenly that I jumped in the car, and rather than bringing the pop-up stand, I brought my wife's yoga mat. And that would have been pretty embarrassing, really, to have just had a purple foam rubber mat to adorn our stand with. So yeah, it felt like it was going to be good, and it has been good. So I always worry about sharing a stage with NHS colleagues, because there might be a perception that everything I'm going to say, all of my ideas have an angle, they're motivated by commercial interests. But as we were doing our preparation, I realised that both Andrew, mine, and Una's individual take on the subject are very, very closely aligned. Before I get into that, just a quick minute about me and what I've been doing. It was 1996 when I first met Dave Smith. I saw Dave yesterday. I don't think he's here today. He was upgrading his 3Com network to ATM. 25 years later, in October 2021, I was on a family holiday. I was standing on the headland at St Ives in Cornwall, and we were busy putting the finishing touches to his shared care record renewal. So I have been doing it a long time. In the last 29 years, I think I've probably done 3,000 face-to-face meetings on NHS sites, and Of course, now we're using Teams, it feels like I'm adding 30 to that every single day. But yeah, I've been around, and hopefully my experience is useful and valuable. The thing that really resonates for me about this session is that I've also made the decision to switch platforms. After 7.5 years at InterSystems, I decided I'd join Synonetics. It was a big leap of faith. I'm really pleased to say 12 months in, I absolutely think I made the right decision. But it's that age-old adage that various people have said throughout the sessions that I've attended, that it's really not about the technology, it's about the people, it's about the culture. That's the thing that really makes things work. And I've concluded that one of the best questions to ask during an evaluation is thinking back to a critical issue within your business. How quickly are you able to identify who was responsible, and then what measures did you put in place to make sure that it couldn't reoccur? And it's a really illuminating question, because people who work within a sort of blame culture, they'll unconsciously just answer that, you know, this happened, it was this person's fault, and this is what they've done to fix it. And that really isn't the way that I think shared care records, which are big and complex with multiple stakeholders, need to be run. So I've been lucky enough now to have worked with 11 of the ICBs, and an honourable mention for the Nightingale Hospital in Birmingham, which, if you were here for Carl's kick-off yesterday, you'll have heard him talking about. He also put up a slide about Everest, that, you know, building a shared care record is a bit like climbing Everest. We had a little adjunct to that, which is that whilst the project might be like delivering a shared care record, if somebody slips, the last thing you want is your supplier not to be there immediately. You want them there holding a rope, mucking in, getting involved and helping, rather than back at HQ writing a CCN to describe how the service will change before they come back and get involved. So as I've just said, culture is the really, really important thing. We need a good cultural fit. I spent the afternoon with Lee, Ian and Sophie at Interweave last week, and amongst the other things we were talking about was how to better engage the third-party suppliers. And sometimes I've seen those conversations turn into a bit of a sort of standoff, where neither organisation wants to take responsibility for driving that outcome. But it was great at this meeting, because we immediately decided that it was a joint effort, that we should play to our strengths. Various people within the organisation should sort of take the lead on it and make sure that we get the right outcome. But of course, when you change platforms, you are going to break the strong partnerships that you've spent the last 5 years nurturing. And that can be really quite difficult. It was difficult for me. Important relationships with friends and colleagues were suddenly just cut off. You know, we'd worked for many years having a sort of common mission and a common commitment to technology, and suddenly that was abandoned, and immediately it left this sort of feeling that not only professional abandonment, but personal abandonment, and that was difficult. But the next point's really important. Making a different partnership choice in 2024 doesn't mean that your previous decision was wrong or that it was flawed. For instance, the government's Cloud First policy was only published in 2019, and ICBs aren't actually 2 years old yet. So the landscape has changed a great deal, and therefore you should be, in my opinion, taking the opportunity to look a little bit outside, see what's going on. The landscape's evolving, technologies, architectures change, and all of that should be embraced. As Una just said, it's not dissimilar to the decision to change EPR. It's big, it's complex, there's many moving parts. And of course, it's a business change project, and we know that many people don't like change, and this might then lead to unhappy users. Your users will have become familiar with the current solution, they'll have adapted to its functionality, and then asking them to change their working practices might not be that welcome. All of this is a recipe for fear, uncertainty and doubt, and it can make it seem easier just to accept the status quo, a contract renewal, rather than really considering your options. But everybody knows that market testing is a good discipline, but it is a time-consuming, it's a high-effort activity. There are numerous positives to it, particularly if you avoid here's 750 compliance questions, please confirm that you meet all of these requirements. Oh, and by the way, if you can't tick that, you probably won't make the next stage. So in my opinion, what you tend to end up with there is 750 questions. Everybody said yes. It's very hard to differentiate. Everybody's done a lot of work, but not to a lot of benefit. So I'm becoming ever more keen on those sort of output-based specification type requirements. They seem, in my opinion, to work quite a lot better. There is this concept of trapped customers, and I think it's really important for you guys to think about your own position and whether you are, where you sit on that spectrum. There's loads of examples of that in my life. My parents-in-law still think the Daily Mail is the quality newspaper it might have been when they were originally buying it. I rock up to see the latest incarnation of Ghostbusters and it's rubbish. And I expect when Teams upgrades that things are going to get better, but sadly, very unfortunately, they don't tend to. And all of this leads to this concept of the sunk cost fallacy, right? I guess everybody's familiar with that, this idea that you sort of good money after bad, you're already committed to something and therefore it's not worth the effort and the time to risk making a change. And there's a couple of hands up indicating that that might be the perception. That's completely understandable. But there is definitely an opportunity to look at different models. There's different contractual relationships. There's different ways that a platform could be hosted or consumed. And as Andrew said, the ownership and the development of that platform, new models are available now. And I think that gives you, as an organisation, the opportunity, as second time around, to leverage your previous knowledge and experience and hopefully to buy a bit better and buy a bit smarter. So I've got a 90-second video now from Red Bull. I think it's really applicable. Oh, I thought I'd remove the soundtrack, but it's back. I'm going to have to speak loudly now, unless the guys up there can fade it out. But basically the idea is that the guys in the wingsuits would be you. The guys in the plane would be me. And we're aiming to hit a very small target to everybody's great excitement and enjoyment. I've probably overstated this. Changing care records isn't quite as exciting as jumping out of a mountain in a wingsuit. But for me, kind of the idea is the same. You know, we're reliant completely on one another. You need to rely on me not to think that there's something more interesting happening elsewhere and just fly off and go for a beer. I need to rely on you not deciding that this isn't too scary and just pulling the ripcord and landing somewhere in the valley. Andrew and I had an interesting conversation about velocities and what happens when the guys actually enter the plane, but they seem to get on all right. But fundamentally, you know, this is all about planning. Somebody will build a Gantt chart. We'll know where we're going to be at a certain time. We'll know our speed. We'll know our projections. We'll have modelled it. And then we'll rely on a project manager and a good team of engaged and committed people so that we truly become a symbiotic team. We've got one another's backs. And ultimately, the success of what we're trying to do is in both of our interests. So, right on cue, that's me. Thank you for listening, and I think we'll now have an opportunity to ask a few questions.
Brilliant, thank you. Some brilliant experiences there, and I hope nobody's scared of flying or falling. Yeah, opening it up to questions. I know I've actually got a couple myself, so I might kick off if that's okay with everybody, and then we can get John to do a bit of an Annika Rice around whilst you guys put your hands up as well. I'm really interested in what do we all mean when we talk about shared care records? What is your sort of product suite or strategy? What do shared care records, what does that mean to you? Because I mean, I've had quite a few conversations between yesterday and today with a few people of, you know, how it differs from each area and what they feel is meant by a shared care record and what it needs to be.
I'll go first. I know Una and I have got a difference of opinion about this. When we chose to go with the Interweave Consortium, Yorkshire and Humber, we had the advantage that Laura's organisation, Leicestershire and Rutland, had gone first. And they had a very experienced SRO, Ian Wakeford, who introduced an IG painometer. And it's a little bit like one of those funds that you see on the side of a church where they're trying to raise £1 million. And without doubt, the highest degree of IG pain, I think, comes when you merge together the direct care use case with secondary uses. And in Nottingham and Nottinghamshire, I didn't say this, but we were lucky enough in that we have already a bespoke longitudinal record built by a GP and one of the former CCGs that effectively we use for planning and population health management. It's actually got a section 251 to allow it to be used both for direct care and for pop health management. So given that we had that, we could then take the kind of lofty view that says our shared care record must just be about direct care. As a result, the IG pain of introducing it is significantly less. Now, that may not be applicable to other people. It could just be luck and happenstance that allows us to have that view. But local strategies have got to be pragmatic to the situation in which you find yourself, not driven by some other entity, I feel.
Thank you.
I've got to say, I don't know that we have a difference of opinion, but I think how we might approach it would be differently. I like this question because I think that we talk about shared care records in various forums, including our programme directors group, which has the title of shared care records, and we're actually all talking about slightly different things. It happens with care plans, it happens with other topics as well, but I think it is important that we as NHS leaders are clear on what we mean by shared care record, and it isn't the thing that the suppliers are selling us, it's what we've decided a shared care record is or isn't. I mean, I agree with it. Its purpose is to serve direct care. I think when you delve below the surface of that is to what extent and how we service that particular requirement. So the types of things that are coming up for us now, for example, are is it the role of the shared care record to provide structured medications data to the acute so they can consume it into their system and incorporate it into the meds reconciliation as they're admitting a patient, for example. So it's that kind of, is it that static, there's a view of data, it disappears again, or is it actually pushing and pulling data around the system so that it can be used still to serve the purpose of direct care? And I think the other thing where we've potentially slightly diverge is the shared care, in the same way as some acute hospital models are to separate their application layer from the data layer, and therefore your data layer is potentially repurposed for research planning, for population health management, and those other scenarios that you might want to use it for. So I don't think that product entirely exists in this market, but I think it's that thing, thinking about what is the future. The products we have today are not probably the products we're going to be wanting to use in 5-10 years' time.
Definitely.
I sort of agree with you both, which sounds a bit weird because it sounded like you were a bit disconnected, but I've obviously seen quite a lot of shared care records. I'm fundamentally a believer in the data saves lives message. It resonated with me when it was first launched, however long ago that was, and it continues to resonate with me. I think that the key to a shared care record is usage and value, and the key to usage and value is connecting as many endpoints and organisations and third parties as you possibly can. I think that Ola did a very good session yesterday about the use of Yorkshire Ambulance with the Interweave platform, and there's a very clear pinch point. Patients who are seriously ill need to go to the place that's got the capacity, can do a handover before they get there, and all of those things. So what I love about the Interweave model and the Interweave partnership is that the board is able to flag ideas for improvement. They can then very quickly be approved by the board within a month or so. And we were talking yesterday, Laura, you've got your ideas portal that your users in LLR are contributing to, and oftentimes 2-3 months later, what they've suggested, what they've posted as an idea can have been delivered. And I think that is unbelievably powerful, and is one of the unique things that drew me to working at Synonetics and with Interweave.
Thank you, that's really good, thank you very much. Any questions in the audience then? Any hands up? Oh, tumbleweed, come on, there we go.
Hiya. Corey Osmaston from Gloucestershire. I've got a question for Andrew. I was interested in your digital charter. That's something I've not heard of before. Could you explain a bit about what the kind of high-level content of that was and what difference it made in doing your procurement?
The best way to get on in the NHS is to steal good ideas from other people. And because I used to work here in Birmingham, I'm still in contact with a lot of people in Birmingham and Solihull, and I saw that they had, at the start of their ICB, created a charter so that they could get some decisions made unanimously before anything started. So I just took that idea into our community, and it was at a time where I needed to glue people together around the Interweave Consortium. It's a little bit different in that you don't have one organisation acting as the sole legal entity with a supplier on behalf of others. It's a little bit more democratic, so we had to describe how decisions would be made, and ultimately it is based upon I can't remember how many 63 different principles affecting both how you manage data through to how you behave collaboratively. And I wish I'd put the link in the slides, but if you hunt within digitalnots.nhs.uk, you will find it. It's 2 years old. It was signed by all the chief execs of the trusts and the councils, but it is out of date, I think, and it's one of those jobs that is on my to-do list to refresh it.
Any other question? Any other hands up in the audience? One. Making John run around now.
I was a bit worried Corey was going to ask me a question.
As soon as John's delivered. Oh! I bet the next question comes from right up there.
Should have queued up some running music, shouldn't we?
Sorry, John, I was just stretching. No. Una, could you describe the process you took to develop your specification before going to procurement? That would be helpful to understand.
Well, our specification, I think, I feel like inviting Corey up on stage for this bit because it was heavily driven by her. At speed was the first thing. I think start to finish, we went from nothing to tender ready to publish in about 3 months. We did 2 things, and we did, well, 3, 4 things. We did a market, what I would call a market consultation, but we did it in 2 ways. We invited NHS colleagues, including your good self, to, we gave a set of questions out, the things that we were concerned about, and did a little survey of trusted kind of contacts, covering the full breadth of suppliers and models that were out there, and invited you then to come and speak to a group representing our board and partner organisations, and that was really, really valuable. I would highly recommend it if the time and the willingness is there to do that. We probably had to do it a little bit faster than I would have liked. It would have been nice to follow up and do a bit more of a deeper dive, but I think really trying to get lessons, really do lessons learned, but with other colleagues in other areas as well as our own lessons learned. And then we did the same thing again with supplier groups, where we asked suppliers to come and answer a few questions to help us build our tender. In parallel with that, we ran a very rapid piece of work locally to consult with end users, what worked, what they liked, didn't like about the current solution, what was missing, what additional requirements they would want to bring into a future one. So there was quite an intensive piece of work to collect those user requirements. And what was nice this time round, of course, was we were we were targeting both users who were actively and high users and those who weren't at all using it, but we thought should have been, so to understand what was stopping them from using it. So it's kind of those two groups, and something else I was going to say about that and it's fallen out of my head. No, it's gone, sorry. That happens every so often mid-sentence, lose my train of thought. But that was a phenomenal piece of work, and all credit to the team for doing that in a very short space of time. But the bit I regret is that we had to do all of that so quickly, because I think there were some deeper, richer conversations we could have had with colleagues in other systems, and to bring our board on a bit more of a journey. Rather than them having to kind of make that quite rapid decision. The other thing I did do, it was more, what was it Andrew said about getting on and stealing from other areas? We definitely had support from colleagues in other areas who shared their kind of specifications and business cases. So there was a lot of begging, borrowing and stealing from best practice from other areas as well, from those that were willing to share. So not much originality in that bit.
But I think that's good, though. I think that's the point, isn't it, of having a collection of people. I mean, like we've mentioned before, MPD, where you have such a good resource base of people with experience in a multitude of different areas, and to utilise that knowledge. You know, we don't have to work in silo anymore. We have access to people and their experience, and why wouldn't you use that? Why would you want to reinvent the wheel every time when these things exist already? Yeah. We certainly don't have resource and capacity to keep doing that every single time, do we?
I've remembered what I forgot mid-sentence, which was the first time round when we were trying to gather requirements, we were asking people who had no idea what a shared care record was, what it could do for them, what difference it would make. To go back and be speaking to educated users was really, you know, it's a completely different experience.
Brilliant, thank you. And oh, there we go. See you in the middle there.
Can I build on that question?
Go wild.
Martin Tennant, that's very loud. I've been procuring shared care records since the very early days of Lycus. I bought 2 of the first 5 Lycus in TVS and in Yorkshire Number Care Record. It's prompted by something Paul said about differentiation of potential suppliers. We've had a lot of conversation yesterday about standards and working towards closer standards, having a core, MBS that we're all working to. So I just wonder, how do you, in that procurement exercise, how do you differentiate between the potential bidders that you're talking to? What are the criteria beyond the all attaining the same technical tick boxes?
It is quite challenging. I think the thing that I've seen working really well is a bit of engagement prior to pushing the button and going into formal procurement. You know, the dialogue, and we've got a good dialogue session coming up with a large organisation in the next few weeks. They've set aside 3 days. They're doing the normal things with product demos and all of that, but then there are specialist sessions throughout those 3 days where we're going to get quite deep and under the covers, and that, I believe, I hope, will give us the opportunity to put some clear blue water between the proposal that we're leading with, which is obviously Interweave and our services, versus the other options out there. And there's always a risk in those situations, because if on one side, on the customer side, there are 15 people, probably only 3 of them will have the deep knowledge and interest in the standards. And so it's always a bit challenging to have my deeply technical colleagues on a short enough leash that I can bring them back and stop them going down a complete rabbit hole and losing the rest of the room. But it is fundamentally important, isn't it? You know, it's very easy for people to say, yeah, we conform to this standard or that standard, but the reality is it's in the doing. And as I say, customer references have worked really well for us. So being able to involve Lee or Laura or Andrew in making
assuming we can bring them along to those dialogue sessions, I think that's the opportunity for the purchasing side to really get a clear view of what's going on. It's not easy though.
Any more audience questions at all? I feel like I need binoculars from here. There was a hand somewhere up there, wasn't there?
Can I add an answer to Martin's question then, whilst there's a lull in hand raising? I think before you go anywhere near procurement or even a decision to procure, you need that really clear what is your strategic, where does your shared care record sit in your wider digital and data strategy? What is its purpose versus, and I think this is where Andrew and I are very much, saying the same thing is, what is your data strategy in relation to the different purposes? So where are you persisting your data? Where do you not want it persisted? And being very, very clear on all of that. Because that then partly drives your decision whether or not you're actually going to procure or whether you're going more the route that Andrew and his team went. So what's your appetite? What commercial arrangement are you wanting? So I think you need all of those things super clear. And if you do then end up in the procurement, you've got some kind of key criteria that you're not getting lost in the weeds of specific features.
No, definitely. Can I ask also, how did you both sort of quantify the amount of business or clinical change support and resources needed when you made the decision to move? Is that something you kind of took into consideration as part of that?
To be truthful, we left that quite late in the process, in that we made the decision that Interweave was the best fit for what we wanted, and we knew we didn't have an imminent hard stop on the existing contract. So only recently we started to look at some of the metrics that we get from the existing GraphNet shared care record. And one of my colleagues who's in the room observed to me that people will often look at those metrics and remember them for quite a long time and forget that they become out of date. So they see something that says, oh, well, 60% of the usage of this is all, say, from the MIG. And that becomes their Bible for the next period of whatever time you're thinking about. But it's not necessarily the case. But we are essentially now calibrating how much business and clinical change we need on the basis of the existing users, because we feel that the existing users, as this is their first shared care record we're going to move them away from. I used the analogy that if you learnt to drive in a Mini, it seemed like a big jump when someone said, here's a BMW, everything works just like a Mini does. And you're a little bit nervous. Once you've done it many times, of course, and realise there's some standardisation, you get less nervous. But we are focusing on those people rather than, as Una said, those who currently don't use something are harder to talk to. So the focus is on the existing users and what usage they make, which drives the change.
Brilliant. Oh, that's great. I think we mentioned it earlier before. I think you mentioned actually, and Andrew, in your presentation. But did you do full business cases for both of your procurements or partnership joining? And I know you mentioned that yours didn't necessarily specifically mention sustainability, but was that a key area of what you wanted to kind of look at in terms of long-term and sustainability, probably from a financial perspective, but also with the change in environments from local or national initiatives and how the new or the moving system you're going to is going to be able to accommodate that as well?
Yeah, so the second thing that we nicked from LLR was their business case. And so we did write a 9-year business case to fit the expected duration of the interweave relationship. And we took it to finance directors, and their initial puzzlement was based upon we never spent any of our own money at all on the GraphNet product. Through a succession of national bids, be they Vanguard or Transformation or Shared Care Records, no one has ever paid a penny for it. Now that I think is dangerous, because that stores in people's heads that these things will always be free, so I don't have to pay that much attention. So although we showed them a business case that showed we were good for a 2-year development period, and that from years 3 to 9 we had at least a £1 million deficit a year, the answer was fine, just carry on. See you when you next run out of money. And partly because we'd previously never had to use any of our own money. So I am looking forward in the remaining part of this year, as we are close to running out of our development money, to go back and say, remember that £1 million deficit? Well, it's still there, and someone's going to have to find it, otherwise we have to switch the thing off, which will be no one's interests.
That is very impressive, Andrew.
Which bit? Which bit?
The bit financing the first one without spending any local money.
I forgot to say, I must put an advert in for using Section 256 of the 2006 Health and Social Care Act. So, because we have extremely good relationships with the Nottinghamshire County Council, and we have a finance expert inside of Digital Knots, we were able to swing the last tranche of NHS public dividend capital into a capital grant. And when that lands in a local authority, 2 things happen. Number 1, you never pay capital charges on it. So if you work out what capital charges are, you know you're getting a loan. It's not capital is not a free good. And secondly, you can spend it whenever you like. Because as far as the NHS is concerned, the money is gone. So they're not hounding you every year to say, have you spent all the money that we gave you, and what have you spent it on? I am persuading that said individual to go to the Interweave event in June, I think it is, to actually explain how you do that. It's more about relationships than rocket science.
Definitely. But really, interesting example there of hiding it away for future use. But yeah, there is obviously ways and means that can be done as well. So. Sorry,
I was just going to say, slightly different in Gloucestershire in that we do use the Section 256 mechanism to good effect, but we still haven't managed to stretch it to not spending any of our local money on. That's the bit I'm intrigued by. In marked contrast, I suppose 2 of our 3 digital directors are also our directors of finance, so we get a lot more scrutiny, full business cases, every penny accounted for, and it's got to stack up for the duration of the bit that's, I suppose, somewhat fictitious. I would say is fictitious is the wrong word. Hard to prove is the benefits case. So we do quite a detailed benefits case as part of the business case. All benefits that if we had to go back, I'm sure they're valid. I'm sure they play out in reality, but measuring them in order to evidence a return on investment, forget it. Not going to happen.
Thank you very much. Right, I think we're actually bang on time. So if there isn't any other questions around, I'd like you all to join me in thanking the panel today for their insights and sharing of their knowledge. And I'm sure they'll stick around if you have any questions for them after this. Now, the session after this one is the closing keynote. So I think we've probably got about 5 minutes or so before that kicks off. So feel free to sit back and relax, or go and grab a drink or whatever you need to come back for then. Thank you.
Okay, good afternoon, everybody. We're now coming, and it is afternoon, we're now coming to the end of the conference. and it's great to see so many people are still here, and hopefully you've enjoyed the sessions you've attended earlier today. So, by the way, you may have noticed I am not Sonia Patel. Unfortunately, Sonia has sent apologies for presenting today, so we are going to keep this brief on the closing side, but it's still very important on some of the items we've got, because we are a community, even a movement people have mentioned to me before today, and we do need to have some level of action from coming together, even though it is nice to see everybody and catch up and have a few drinks together. So before I get to that point, I'd just like to put out a few thank yous. I'd like to put a thank you out to the committee and also to the organisers as well. Without that group who helped put together the schedule today, persuade speakers to attend or organise the actual day, it wouldn't have been the spectacular event that we've actually attended. So thank you very much, everybody. Okay, I'd like to thank the sponsors as well. Without the sponsors, my budget would be even more in deficit than it is at the moment. And to be honest, it is important that we work with our vendors and suppliers in partnership. As mentioned in the last session in this hall, we can't work in isolation. We need to work in a very efficient manner and effective manner with our partners. And having them in the room, even if they do help us fund the event, is extremely important. So I'd like to say thank you to InterSystems, Synenetics and Orion, GraphNet, EMIS, Better, EY, Restart, the Egress Group, Channel 3, DigiSafe, Deloitte, Apera, Maywoods and Smartco Health. That's the whole list. Thank goodness I remembered to bring a brochure in. Albeit very important, all of them very good to work with, good experiences, and definitely worth a conversation with. So now coming to the final and more important points of the day. This morning, and Carl mentioned as well yesterday, we need to have some level of action from the event, because again, we need to measure success from one year to the next. I mean, last year there was a big focus on NRL, and maybe we haven't made the progress we would have hoped to have made on NRL and ambulance service, but it is progressing, and there is movement, especially on, if you attended the Southwest presentation on ambulance yesterday, and the progress that's being made there, and also most of the care records are now starting to get connected to NRL. It is a start, it's not the end of the journey, but at least it starts pulling something together that can add a greater overall value. So the items I've picked up from talking with colleagues and from feedback, there's a number of items, and what I'm going to do is run through the items, and then I'm keen to try and get some interest in a couple of people from the audience. No pressure, I'm not going to get everyone to stand up and be recorded like last year, as I did. But yeah, just from a point of view of where we take some of the next steps to really form our action. So the first one that's really come up is, what can we do nationally? What can we work with NHS England to do once and share many? And there's examples with farmer outcomes. So, well, LLR have done work with farmer outcomes in West Yorkshire. Can we do that as one-off? Can we work with a vendor once and then link to many? Or care planning? Can we do something consistently that way, even if it's just sharing the assets and having a reality about standards? And it's really helping to head that conversation on what we can do once and share many, rather than hoping somebody will come up with that idea. So that's the first one, hold that one. The next one is developing GP Connect into a structured data set. Now, we've got basically a website view, and I think there's a high level of frustration that it hasn't progressed at pace, and we haven't got more structured information, which is quite important if we're trying to get the right information in front of the right person at the right time. That one's come up quite a few times, so yeah, hold that one as well. Information sharing, it's the wicked issue that's come up every year. I think I've been to one of these, or at least for the last 10 years, if not longer. Why we can't resolve the issue of national, around information sharing at a national level, and we end up with such a high level of complication. I mean, Carl made the point of NRL against local shared care record and having to go out and get another sharing agreement in place. There's so much complexity for something that really should be reasonably straightforward, but also protects the privacy of people if necessary. So that's that one. Also, we've got the call to action from Gary to look at how do we connect England, maybe the UK. I can't remember if it was England or UK on that one, Gary. You don't need to answer that one now, but I'm sure it'll be on the letter. Push that one forward. Without that backbone to then move and that way of connecting to create something now and later, and how we link our information together in a way that works more effectively. We are going to carry on with these border issues. We're going to carry on definitely with border issues between countries, border issues between patients, and we're still going to end up with organisations like ambulance services that just find it really difficult to get the right level of information. And then the final one that's come up is maybe we need a special interest group with our professional bodies, FedIP and BCS. There are other professional bodies out there, by the way. They're just two I've come up with. To help us, shall we say, from an independent point of view, provide leverage and expertise to national bodies on the way forward. And that might be a more succinct and effective way to get our point across on some occasions by using the profile and the knowledge of them professional bodies to more eloquently put our messages, especially if it's Mr. Rickles on one of his rant modes on the digital program director. So they're the ones I've got down. Now, what I would ask is, what I would suggest is we put them out after the event, and we look for interest in people that would help form how do we take these aspects forward. And if we don't take any of them forward, we've probably failed today for moving forward as a shared care record community. Hopefully we can at least take 2 or 3 of them forward. It'd be great if we could take all 5 of them forward. And based on the fact we are talking hundreds of people here, to take 5 actions forward and at least get to the next stage and decide where we're going is something we should really aspire to achieve. Something that's necessary for all our shared records to go to that next stage. Something that if we don't solve, we'll be here next year, location and host to be determined, and we'll be talking on the same issue. So that's the sort of wrap up on the action. So I'm now going to open for any other items that people have thought of. Sorry, John, I know you're going to have to run around again, because we've got the fittest and the youngest person in the room to do that running around. Definitely one of them is possibly true. Just on any other items that people think we should add to that list. Oh, sorry, I forgot about social care as well. But the social care was positive, that we tried to change the language to not be so health orientated. So Steph did raise that from her group, that it does feel like we're becoming more inclusive in that respect. So yeah, any other items in the room that feel we should add to that list? I can't see the hands, John, so I am totally reliant on you. Don't worry, John, next one will be at the bottom. I think somebody's just rushing down now to ask it.
Thanks, Lee. Firstly, really good conference. Thank you for everyone involved. If we're not careful, there's a risk that we might go scattergun in trying to establish what's happening with national funding. I think if we can try and align our voice in order to prioritise share care records to support productivity gain, so that there's one clear voice rather than hundreds, I think that might be really productive.
No, really good point, John. Especially, maybe it's the preparation this year, but there's a big focus on productivity. So there probably is what are the productivity gains? Where's the benefits? How can we use that hook in? Because shared care records, or at least sharing of information to get it to the right place at the right time, should improve productivity if we've done it right. So yeah, really good point. We'll add that one to the list, John. Any other hands? Okay.
Hiya, it's Laura, LLR. I just wanted to comment on the GP Connect side of things, really, because I feel like it does almost feel like this year's NRL big wicket issue, doesn't it? That GP Connect came up in a lot of the conversations that were had in quite a few of the sessions over the last day and a half. And I think from a program directors group as well, we've already done quite a huge piece of work of getting a lot of organisations together to discuss what our challenges are with GP Connect, what we want them to help us move forward with. And we had submitted a report to them sort of not last month, month before, I think. Where are we now? April. Yeah, wasn't it 2 months ago now? And I think they, if I might remember rightly, they'll be attending the next program directors group to update on some of those items. And it almost feels like it's an extension of that, so maybe not a whole new task altogether on GP Connect, but an extension of some of the work that's already being carried out. But also really interested in some of the items that came up in some of the conversations over the last day on particular items within GP Connect that are part of the data set that aren't released as part of that GP Connect feed. So it's almost like there's a hidden load of information that we can't get access to that actually people are screaming out for as well. So hopefully we can get that into the conversations as well.
No, it's a really valid point. This doesn't suggest that we stop doing what we're already doing.
No.
It means we coalesce and become far more focused. And shall we say, we have struggled with GP Connect being engaged, or at least the API team, because of their priorities. Here's the opportunity to really labour the fact it is a priority. And if we don't get that data in a structured way, we're going to make it really hard. So there's a lack of productivity gains there. So yeah, absolutely valid. I'm not suggesting we create another industry around it, Laura. I'm just saying these are the points that have come up. So let's sweat them assets, and let's make sure we recognise that for a year's time when how far have we come. And you're absolutely right. GP Connect needs to be one of them. Okay.
Yeah, thanks a lot, Lee. It has been a really good conference. Something that came out of the sessions this morning when you're talking about benefits and One London, talking about not how difficult it was, but the level of research and what struck me was that coming out with the benefits was fantastic because the benefits were huge. The thing is, it also helped you understand the levers by which to be able to get those benefits. And what I raised there was, doesn't that help you define some best practice that you want to share across the other shared care records? Not just here's the benefits, but here's the levers that we use to understand how we get those. And whilst different shared care records are going to have some differences, the levers I think are really important. I think those could be shared, and also shared to NHS England as well as across this community to see, how we can make that better, how we can improve that, and how we can communicate that to NHS England.
Yeah, absolutely valid, David. And I would suggest we tie that into the productivity conversation, but it's having, as you say, it's having the assets and the shared knowledge, so we're not reinventing the wheel. And I think, to be honest, there is already a wealth of information in NHSE. The issue is we've had a knowledge loss based on the current reorganisation, and I think there's an opportunity to probably strengthen that within this community because we have the knowledge that we've shared, and it's just how we make that a stronger and more evidence-based approach as well, which is absolutely key. So yeah, I absolutely agree. Any further questions? I think we now got, we're just going to pass it up. It's a bit like a pass the parcel. So unless somebody stops halfway and asks a question before it gets to the last person, of course.
I'll come down to you. Is that better? It's not much of a question, really. It's more of a confirmation of a lot of people that have been talking about the funding aspect. Manal spoke about the business case that we've put forward from Shared Care Records, which you hopefully all know about. We've been talking about it in MPD, but it's also to just confirm that the amount that we've put in for NRL or another option or however we're going to facilitate that via our various maturity of our systems, is going to be distributed as per the quotes or the funding, and that no one will not receive funding. I'm not sure where this has come from, but we're not discriminating. Everyone will get their equal share.
Okay, that's good news, good news. Obviously, funding's always a popular one. Yes.
That's
yeah.
why I brought
so
it up,
what
Lee.
we're going to do is give it all to Andrew, so he can put it in there and we don't pay capital charges. So I think we'll close questions at that point, just so we can make sure we finish at 1 o'clock. So I don't want to overrun in case people have got trains to catch. Or,
I could
you
come
know,
down that
have
stairs. It doesn't matter which side I'm on. Whichever side I'm on, it'll be somebody on the other side.
Okay. Okay. So, just to round up, we are looking for a host and a venue for the next year's event. So, obviously, we're at Birmingham this year. We've been at Leeds. I mean, I must be honest, if we end up, I don't know, if we've got any international locations, I'm quite happy to go to Barcelona, if they're willing to host. But with all seriousness, any shared care records that might show an interest in hosting next year's event, because it is a community, and we do need to travel around the country, host it in their location, that would be brilliant. If we can pick that one up with the current committee, that would be really good news. So that's one thing. And the final thing, just to wrap up the day, I think we should all just give ourselves a clap. We've put quite a lot of time together. Everybody's added value to today's session, and especially you people that are still here at the end of the event. You know, it's us that make it work. It's the community that makes it work. So let's have a final round of applause for everybody involved, including speakers, attendees, suppliers. Okay, and on that point, we'll close the event. There is coffee and some sweet snacks, I believe, outside, wherever the coffees and sweet snacks are. And then hopefully I'll see you all again very, very soon.